Where are we supposed to see?
This is the camera. Can you see the green light?
Yeah.
It can be like a conversation also. We make it more interactive. Am I ready? Yeah? Should we start?
Start.
Okay, Mihir, I'll introduce. Okay, good afternoon. We are all, I am Dr. Sita Jayalakshmi. She is Anuja. Anuja Patil, he is Mihir Parehh. We are all consultant neurologists at Krishna Institute of Medical Sciences. And first of all, we welcome you all on the occasion of International Epilepsy Day on the 8th of February. It is celebrated in the support of persons with epilepsy all over the world to create awareness among the doctors, general public, to support the cause of epilepsy, both for the persons with epilepsy and their family members and the caregivers. So on this occasion, Krishna Institute of Medical Sciences is organizing this meeting on management of epilepsies. So now it's my pleasure to request Mihir Parehh, my colleague. He will be talking about the important aspects in the medical management of epilepsy. Okay, Parehh?
Good afternoon, everyone. So, as we know, epilepsy is very common worldwide. If we see the prevalence of epilepsy, worldwide more than 70 million people are affected by epilepsy. If we see Indian data, they say more than 12 million people are affected by epilepsy. So, every 1,000, 3 to 10 persons in India are suffering from epilepsy. Plus, if we see the incidence of epilepsy, they say per 1,000 per year, 0.2 to 0.6% patients develop epilepsy. Plus, out of these patients, around 20 to 25% are drug-resistant epilepsy. So, India has a very high epilepsy burden. So, before starting, what is epilepsy? So, when we say epilepsy, is if any person develops more than 2 unprovoked seizures, more than 24 hours apart, or a person develops single unprovoked seizure, but chances of developing second seizure is more than 60% over next 10 years in compared to general population, or the patient is suffering from any epileptic syndrome, then we say patient is having epilepsy. Now, to diagnose epilepsy, most important things is history. So, most important thing is you have to take history from the person who has witnessed the seizure. So, if any patient come to our OPD, our first thing is to differentiate whether it is a seizure, whether it is a syncope, whether it is a transient ischemic attack, or whether it is a non-epileptic spell. So, a careful history will able to differentiate both of this, because many times we unnecessarily label the patient with epilepsy, and they are put on AEDs. As we know, AED can have some side effects also. Plus, we have a lot of social stigma for epilepsy. So, that's why correct history is very important. Plus, next thing, if the patient comes with seizure, so history-wise, most important is whether we have to differentiate whether it is a focal epilepsy or it is generalized epilepsy. In case of generalized epilepsy, we have to further classify. There are in classification there is generalized tonic-clonic seizure, myoclonic seizure, atonic seizure, in which patient just fall down, and absences, in which child just become blank for a few seconds, or patient is having focal epilepsies. Generally, a common clue for focal epilepsy is patient is having subjective sensory phenomena, which is called aura. So, important history is able to classify as patient is having generalized epilepsies or focal epilepsy. Why? Because prognosis of both is different, choice of aid is different in both of the aspects. So, after careful evaluation, we need to investigate the patient to find the cause, because there is something called symptomatic seizures. Symptomatic seizure means seizures are provoked by something. A patient is there, he develops hyponatremia due to some other reason, he develops seizure. Then our first goal is to correct the underlying abnormality. We also give anti-epileptic medications, but for brief time only. So investigation are important in this way. Plus, if we see age-wise, so in young adults in India, neuroinfections are common, like neurocysticercosis, tuberculosis. So they are very commonly caused for epilepsy. Plus any injury, head injury, it causes post-traumatic injury, epilepsy. And if we see elderly population, so in elderly, we should always rule out red flags like tumors or any ischemic seizure, like patient is having acute stroke or embolic stroke, which presents a seizure. So investigation like MRI will helpful in finding out the etiology of seizure. And EEG, one of the most important things for epilepsy is EEG. EEG will help for detect electrical activity in the brain. So EEG will help for whether the epileptic form abnormality are generalized, patient is having focal abnormalities, or what is the frequency, like the burden of the electrical activity or how much in the EEG. So that we can correctively treat the patient. Once we identify the patient is an epilepsy, then we plan for the management of the patient. Now, any epilepsy patient, we have 3 goals in management. First, most important is the seizure control. But simultaneously, two most important aspect is we want to minimize the side effects. And third is we want to improve the quality of life, or we want to restore the quality of life. We have patients like what stop is education. Children are having daily or weekly seizures and they have stopped going to school. Plus, people are afraid of marriage. So, if we give correct AED, if we improve their quality of life, they will be more happy in their life. Now, how we will choose anti-epileptic medications in case of epilepsy? So, we have 3-generation anti-epileptic medications. Like anti-epileptics like carbamazepine, phenytoin, phenobarbital, clobazam, valproate, we are using since decades. They are first-generation anti-epileptic medications. While there are some second-generation that we are using since last few years. They are levetiracetam, zonisamide, lamotrigine. So this we are using plus pregabalin, gabapentin, which are using since last few years. And recently there are a few new anti-epileptics have come. They are third-generation like perampanel, brivaracetam, lacosamide, vigabatrin. So correct AED should be used for correct disease. So whenever patient we diagnose with epilepsy, we should always start on single anti-epileptic medication. For any patient we initiate, combination should be avoided to start with. So if we see focal epilepsies, so commonly used medications are carbamazepine, phenytoin, and clobazam we use commonly as an add-on therapy in case of focal epilepsies among the first generation of medications. While valproic acid is the drug of choice for generalized epilepsies, which are generally genetic epilepsies. But however, if we know in female patients, we generally avoid valproate because of side effects. So levetiracetam we commonly used in that type of patients. In case of absence seizure, ethosuximide is the drug of choice. Now, second aspect to see is patient is having comorbidities. Suppose some patients having cerebrovascular thrombosis, they are on anticoagulant, so they are taking warfarin. So many AEDs will interact with them. Enzyme-inducing AEDs will interact with that medication. So always history-wise, patient's comorbidity is important. We should adjust the medicine according to that. So we should avoid medications like phenytoin, carbamazepine in patients who are taking warfarin. There are some AEDs like lacosamide, levetiracetam, who doesn't interact much with the warfarin. So we commonly choose that AEDs. Suppose a patient is there who is having kidney disease, in which we try to avoid few AEDs. Like we have to adjust the dose of the anti-epileptic medications. We should have to reduce the dose of levetiracetam. But phenytoin can be used safely. Brivaracetam can be used safely in patients with kidney disease. Similarly, if patient is having cirrhosis of liver, patient is having hepatitis, patient is taking TB medication, and he is having high chance of liver injury. In these patients, we should choose the AEDs which are safe for liver disease. Levetiracetam, lacosamide, they are safe, less interaction, and we can give in patients with liver disease. So, if we see some other ADs, like recently I want to talk something about newer ADs, brivaracetam and perampanel. So brivaracetam is a medicine which acts in synaptic vesicle 2A. Same mechanism which levetiracetam acts, but it is 20 times more faster in its mechanism of action. So if we see side effects, so many patients on levetiracetam develop behavior disturbance, irritability, and anger. Though it is described, but relatively less common with brivaracetam. Plus, one more advantage is in patients with drug-resistant epilepsy, brivaracetam is more useful. However, we should never start this third generation AIDs as a first online medication. Patients should be on appropriate medicines, try medicines which are used for decades. And if they don't respond to it, then only we should switch over to newer medicines. Plus, sometimes patient doesn't respond to one medicine. So in that, we use combination of medicines. So by using the combination of medicine, what we have to see is we should not combine the medicine which are the same mechanism of action. If we see carbamazepine, phenytoin, they are sodium channel blocker. But if we see lacosamide, it inactivates low sodium multiplicated channel. So lacosamide we can combine with other medications. Similarly, perampanel, it acts on AMPA receptors. So medicines we should always combine which don't have similar mechanism of action. So that's all. And any question we are ready to answer. Now, my colleague, Dr. Anuja Madam, will speak further on women with epilepsy.
We'll come back to the question and answer phase towards the end of this session, maybe. After the brief description about what all medical management options are currently at hand, at least, little more knowledge about handling epilepsy in women. Why this subpopulation is more important, not just because some epilepsy syndromes, especially the IG or JMEs, will be more prevalent among the women subpopulation, but handling women with epilepsy, we have very narrow safety margin. Options, the entire list, out of the entire list, hardly few will be available for us during the reproductive age group. And the long-term consequences for the long-term childbearing age group, the reproductive outcomes will be borne in my mind. So to take you through this, we'll go a little phase-wise. Initially, generalized seizures, IG, JMBs are relatively more prevalent among women or girls, especially the juvenile age group, 16 to 26 around age group, they'll be more prevalent. Most of the patients, almost 2/3, 70% of them will have seizure precipitation during or around their menstruation. Not everything gets labeled as catamenial epilepsy. Catamenias, what was initially known as a monthly precipitation of epilepsy, can happen during the mid-cycle, that is the periovulatory phase, or else during the pre or post menstruation itself. So baseline, compared to the baseline, if twice double the amount of seizures are more during this specific time lock period, then they are labeled as catamenial. Not necessarily each of them are going to be started on Dimox, as has been correctly mentioned in the books. Simple addition of clobazam 10 mg or 20 mg, or else a light increase in the baseline medications itself during 2 days prior to or 5 to 7 days throughout these phases can be helped to manage the seizures which are occurring during these phases. So coming down to the hormonal consequences, as was told, like half of the, especially the first generation antiepileptics, they have enzyme precipitating potential. So women which are using some hormonal contraception should be pre-warned regarding chances of contraception failure. Per se, seizure or epilepsy is not going to reduce any reproductive potential for such a women. Recently, literature has been shown, compared to the healthy counterparts, women with epilepsy have the same sexual activity, potency to have pregnancy and continue throughout and both live births. So, counseling during this specific time periods, wherever women are opting for conception, that should be started prior to the conception. So women should be advised regarding preferably use of some interferent devices, avoiding any hormonal contraception while they are on first line antiepileptic medications. And those post-marriage or so should be pre-warned regarding the potential side effects or teratogenicity of the medications. Compared to the general population, wherein the chances of getting any congenital malformations or so is hardly some 2 to 2.2%. These women with epilepsy will have that chances around 3 to 5%. And that happens more for women who are on polytherapy, and especially when the drug exposure is during the first trimester. Most often women come back to us after the confirmation of pregnancy, that is already some 8 to 12 weeks of the pregnancy, and this important period of first organogenesis has already been over. So changing over of medications during the late phases of pregnancy may or may not add any subsequent potential to the child or the fetus. So safer options, especially levetiracetam, lamotrigine, clobazam, which have been known since ages, should be advised to women who are likely to conceive over the time. Again, seizure control is much more beneficial, or should be given prime importance rather than expecting those adverse effects. People or women who have been very well seizure controlled or who have been in remission, they tend to do much better in terms of pregnancy outcome as well. So take time to manage the epilepsy, get them under control, under remission, and then maybe they can go ahead with the conception and further pregnancy plannings. During the pregnancy, monitoring of antiepileptic doses or levels may not be available all throughout, and is not advisable provided the epilepsy or seizure frequency has been pretty well under control. So monitor the changes for women who are having frequent seizures. For such a women, seizure levels can, or the antiepileptic drug levels can be done prior to the pregnancy as well, and during the pregnancy, those levels have to be monitored only if the seizure frequency is increasing compared to the baseline. Especially during the second and third trimester, when they are likely to put on, there is a wide weight gap. At that time, increasing the doses of baseline antiepileptic drugs is advisable, and this has to be continued post-pregnancy even up to the puerperium. These last trimester and postpartum phase are likely to be the time periods wherein seizure precipitation can be expected. So not just antiepileptic dose management, but frequent psychological counseling, family backup support should play into part. People during the postpartum or the pregnancy, after the delivery of the child, antiepileptics can be continued in the same doses. Only mere instruction that taking the doses immediately after the breastfeeding. That ensures that as far as possible we are trying to keep the drug exposure to the minimum for the baby. So during the pregnancy also, as we had just discussed, levetiracetam, lamotrigine, clobazam to some extent have been proven to be safer in terms of the further fetal outcome. For people who are females who are very well controlled on any other antiepileptics also, low dose exposure to valproate even up to 600 has been found to be safe during or throughout the pregnancy. And rather than changing the medications during the first or second trimester for a lady who has been very well controlled on baseline antiepileptics, it will be ideal to just monitor the fetal consequences, frequent fetal monitoring in terms of TIFA scan, and as per the advice of the gynecologist, maybe an invasive monitoring in terms of amniocentesis or CDS during the second or third trimester should be advised. Need not be like epilepsy or having polydrug therapy is going to have a adverse outcome. Most of the females, almost 70 to 75% of the females do carry on pregnancy and have outcomes as compared to their healthy counterparts. So other drugs, especially carbamazepine, oxcarbazepine, lamotrigine per se, is likely to have changes into the drug levels, especially around the second and third trimester based on the protein binding. So these drugs and their blood level monitoring can be advised if the patient is having recurrent seizures. Provided that seizures are very well controlled, same doses can be continued throughout and after the pregnancy. Patients coming to the next age group, females which are menopausal or perimenopausal. Again, this is another time period during which seizure precipitation is expected, especially for females who are having perimenopausal symptoms. So these should also be very frequently monitored. Antiepileptic doses changed accordingly. Another side effect or should be borne in mind is osteoporosis. For people or females who have been on valproate, carbamazepine, phenytoin especially, they are likely to have much more worsening in the loss of bone mineral density. So frequent monitoring is, if required, DEXA scan and subsequent calcium vitamin D supplementations during these age groups. Another point to be board is, during this time, any new onset epilepsy, especially when associated with some cognitive changes or behavioral changes, should alert a possibility of autoimmune encephalitis. Elderly age group need not be just the younger female population with ovarian teratomas who are likely to have NMD encephalitis. Compared to at the same time, elderly women during the perimenopausal, postmenopausal phase, if they have recent worsening in the seizure, recent worsening in their cognitive status, should be subsequently evaluated even for the possibility of autoimmune encephalitis. Regarding, apart from medical management, surgical outcomes also, female compared to male, these both groups studied together will have equal surgical outcome compared irrespective of the etiology. Although chances of cryptogenic localization related epilepsy, cryptogenic in the sense their MRI imaging, everything comes out to be grossly normal. Chances of cryptogenic are relatively more common in women. So, provided all the medical and antiepileptic doses are discussed, all these options which are available, their likely teratogenic potential, but side by side, seizure freedom and subsequent seizure remission should be discussed on par with the family. The most important stigma which comes in is disclosure of the diagnosis as well as being on treatment. So, very well controlled epilepsy patients are found to be relatively more favorable in being compliant with the medications. But whenever the seizures are relatively not well controlled, if they tend to have seizures despite polydrug therapy, onset for such a patients, counseling on par with the neurologist, psychologist, and family together, along with some social support, is advisable. Coming down to the surgical management, Dr. Sita, she will brief us about the surgical management.
Thank you, Anuja. So before we go into the surgical management, we have heard very nice brief reviews about management of epilepsy by Dr. Mihir Parehh and management in women by Anuja. I just want to say the pearls and the pitfalls in the management before I go to the drug-resistant epilepsy. So whenever we are choosing a management of epilepsy, the first and foremost is always take a good history, as already said, and decide what is the seizure type. First of all, whether it is epilepsy. Epilepsy means 2 or more than 2 seizures. Once it is epilepsy, decide whether it is broadly partial epilepsy or generalized epilepsy. Once it is partial epilepsy, there is no problem. In generalized epilepsy, we have 3 seizure types. One is the absent seizures, one is the myoclonic seizures, one is the GTCS. So whenever you have a history of GTCS or myoclonus or absence, go for a broad spectrum anti-epileptic drug. The broad spectrum anti-epileptic drugs will be, the first and foremost is sodium valproate. Other ones are levetiracetam, and even topiramate comes under broad spectrum. Whereas for the focal seizures, always better to start with one of the first line anti-epileptic drugs as per the guidelines of American Academy of Neurology and also the NICE guidelines of UK. Always in a focal seizure, start with oxcarbazepine in children below the age of 12 years and above the age of 12 years, start with carbamazepine. Nowadays, we see many people just being started directly on the broad spectrum and also the latest newer AEDs, which are very expensive. So we should always follow these guidelines and start them according to the type of the seizure. That is the monotherapy. As far as possible, we should see that they are well controlled on monotherapy. That is, we should reach to the maximum possible dose per kg of the person or the most tolerable dose. Sometimes, even if it is 10 milligrams per kg, the person may not be able to tolerate it. So in such case, we go for combination therapy. So in the combination therapy, like already discussed, always combine one drug with a different mechanism of action or a drug with single drug mechanism of action with multiple mechanisms of action. All these broad spectrum AEDs are the ones who are having multiple mechanisms of action. So we can combine the first generation like phenytoin, carbamazepine, oxcarbazepine with broad spectrum. Like we can combine with valproate or even slow channel like lacosamide or even the other like topiramate. So only when they are not controlled, then we should think whether are we dealing with a drug refractory epilepsy. Then before going to the drug refractory epilepsy, even in women, most important is again the drugs which are safely used in women, especially those who wants to conceive, especially during the reproductive ages, levetiracetam, lamotrigine, and to some extent clobazam. All the other drugs have some risk of malformations. But again here the important principles are, whenever somebody is on monotherapy, the risk of malformations is very less. So try to go to the maximum dose of single drug rather than combining multiple drugs, especially in women who are planning pregnancy. So the guidelines in the management of pregnancy are, first of all, any woman who comes to us even before marriage, we should be informing them about what are the possibilities of using the drug or suddenly conceiving on the medication. And always give a pre-conceptional counseling. It means before conception only we should explain to them which drug is safe, and also they should be on folic acid regularly, because most of the time women come to us after conception and say that they are not on folic acid. So it's a must that a pre-conceptional folic acid should be given. And also once they conceive, there is no point in changing the anti-epileptic drug. The choosing of the right drug for the woman for the right syndrome should happen before the planning of pregnancy. And once conception is over, except for sodium valproate, we do not change any other drug, because sodium valproate is known to cause cognitive impairments with the IQ of around 10 to 20, lesser than the peers after when they grown up at the age of 6 years or 7 years. That is good evidence. So valproate is contraindicated in women who want to have pregnancy. During pregnancy, it should not be used. And even if they conceive, then remove valproate and we can start them on either lamotrigine or levetiracetam. And also the folic acid should be continued till the delivery. And another important aspect is all the anti-epileptic drugs during the pregnancy should be increased by 30% during the last trimester. For example, if a person is on 1 gram of levetiracetam, it should be converted into 1.5 grams during the 3rd trimester. This is because of increased hemodynamic circulation and weight gain and other issues related to hormonal interactions which are related to the pregnancy. So now we will move on to the difficult to treat epilepsies. We call it as drug refractory epilepsies. Normally, if you look at 70% of the epilepsies are very well controlled either on monotherapy or at combination therapies. But 30% of the persons with epilepsy never get controlled on medication. They keep on getting the seizures in spite of 2 AEDs, and of which means they can be having continuous seizures which can be daily, weekly, or once in few months. Or some people, another 10% of them will be going into remission and relapses. Means they will be controlled for 3 to 4 months, and after that they will get clusters of seizures and again go into remission. So this group of epilepsies is quite challenging, and all these persons who have uncontrolled epilepsies, the definition for drug refractory epilepsy is any person who is on at least, we can follow the rule of thumb of 2. That is, they have used 2 drugs either in combination or one followed by another anti-epileptic drugs was used for a period of more than 2 years, and they are getting at least 2 seizures per month. So if such a epilepsy is there, they are called as drug refractory epilepsies, and they should be referred to specialized epilepsy centers where the evaluation for a possible surgical option can be made. Here it is very important why drug refractory epilepsy is important. So as Dr. Mihir said, it's not only freedom. The most important thing is cognition, behavior of the person who has epilepsy, which matters especially in children with epilepsy. And the next one is the quality of life of the person with epilepsy and their family members. Because whenever people are having continuous seizures, you don't know when they will get the seizure, where they will get, what are the injuries. And not only that, most of these people with drug refractory epilepsy will have a structural abnormality in the brain, which can be picked up easily on MRI in almost more than 80% of the persons with epilepsy. The same structural abnormality in the brain is responsible for developmental delay, especially when the epilepsy starts at very young age, like 2 to 4 years of age or below the age of 12 years. And this leads to not only the uncontrolled seizures, it leads to developmental delay, where the child will be few years behind his peers because of the continuous seizures. And the third one is this leads to significant developmental behavioral abnormalities in the form of attention deficits, not concentrating, hyperactivity, not listening to the parents, teachers, not able to learn because of lack of attention. And some children with epilepsy, refractory epilepsies, also have associated autistic features. So it's very important that once a child has epilepsy, we evaluate not only for the seizures, you have to evaluate for their cognition, means what is their IQ and development. You evaluate their for behavior, and you have to address all the three issues holistically. Similarly, in adults, uncontrolled epilepsy, usually when the epilepsy starts after the age of 12 years, most of the times the development is normal, but it may be affected, it may affect the behavior. So if the behavioral problems may be either because of epilepsy itself or may be related to the drugs which are used in the management of epilepsy. So this can be, as doctors, all of us can identify what is causing the problem and we should be able to address the issue. So finally, in drug refractory epilepsy, once they are referred to centers like where we have a comprehensive epilepsy surgery program, what happens, how do we handle these drug refractory epilepsies? So all of them, whenever a person with drug refractory epilepsy comes to us, you take a good history and make sure they are really refractory. You are not dealing with any non-epileptic attacks. And after that, we do a 3 Tesla mRNA brain, which has epilepsy protocol, dedicated epilepsy protocol. According to that, once it is done, most of the time we can identify a structural abnormality in the brain. mRNA identifies the structural abnormalities, which can be in the form of a low-grade tumor, especially in children. The second important, the tumors are usually dysembryoblastic neuroepithelial tumors, low-grade gliomas. Sometimes even you can have vascular malformations like cavernomas. Then the most important is hippocampal sclerosis. Hippocampal sclerosis is one of the most drug-resistant epilepsies, and it is surgically remediable epilepsy. Then other important, this is usually seen in adults, hippocampal sclerosis. Whereas in case of children, we see other issues like malformations of cortical development, where one part of the brain has a focal cortical dysplasia or a developmental abnormality. In addition to this, one can find some scars in the brain, which is, we call it as scar epilepsy or gliosis related epilepsy. So these are the 4 important causes, that is low-grade tumors, hippocampal sclerosis, focal cortical dysplasia or malformations of development, and gliosis. Once we identify, it's very important to make sure that from where the seizures are taking their origin. So this is confirmed by doing a prolonged video EEG monitoring, where we admit the persons with epilepsy in the video EEG monitoring unit, and we reduce the anti-epileptic drugs. Sometimes we even stop after 1 or 2 days and make sure we record anywhere between 2 to 10 seizures, which are the habitual seizures. Once we record the seizures, we will know that whether seizures are coming from the right hemisphere or left hemisphere, whether they are coming from the frontal, temporal, parietal or occipital. After this, the person with epilepsy also undergoes functional imaging like FDG PET, ictal spect. Ictal spect is you inject a dye during the seizure, and the dye goes and sits in the area from where the epilepsy takes origin. So after doing all this, we call this the so-called multimodality imaging. Once all this is done, if there is a concordance in the video EEG, ictal spect, but after this, the person also undergoes a detailed neuropsychological evaluation to identify what is the IQ, whether there are any deficits are present, like temporal lobe deficits or frontal lobe deficits. And we also do visual fields, especially when it is located in the temporal or occipital lobe, to make sure the baseline visual fields are normal. Once these are all done, if it is a clear-cut lesion, most of the times they undergo surgery, where you do a resection. The types of surgeries which are done are usually commonest surgery done all over the world and also in our center, where 70% of the surgeries are temporal lobectomies, especially for hippocampal sclerosis or low-grade tumors located in the temporal lobe. So you do a procedure called amygdalohippocambectomy along with anterior temporal lobectomy. So the resections are equally done on the right as well as the left side, though they have concerns about memory, language impairments. But usually, following surgeries, the memory, language usually improves or remains the same. Very rarely deteriorates. The second type of surgery is a hemispherotomy, where you do this for hemispherical epilepsies, which are common in children. The third type of surgery is for extratemporal epilepsies, where you do a focal resection, that is a focal cortical resection, or sometimes if the lesions are large, you do a partial lobectomy or a lobectomy. And sometimes we do disconnection procedures, where you disconnect the part of the abnormal brain from the rest of the brain without removing the abnormal part. The commonest example for this is posterior disconnection. So finally, depending on the location of the lesion which is causing epilepsy, the type of surgery is planned. And sometimes we encounter people with drug-resistant epilepsy where the MRI is absolutely normal, and then we do the other multimodality imaging techniques like FDG, PET, ICTER, SPECT, and PET MRI fusion. And also after that, we place electrodes in the brain, that is called stereo EEG, and then you map the area from where the electrical activity is coming, and followed by you identify the area and go for a dissection. So after all this, most of the times the concerns are what is the success of epilepsy surgery and what are the risks associated with this. So these are very common conversations, and people are very apprehensive before the evaluations. But nowadays, with advances in neurosurgery, with excellent equipment available, it is something like navigation, where you can exactly go to the epileptogenic zone and resect that very safely, with a mortality rate, I will say, is less than 0.01%, and a morbidity means getting a weakness or a deficit of less than 1%, unless it is located in a very eloquent cortex like a motor cortex. The second one is the outcomes all over the world are best for hemispherotomies, where they have excellent outcomes with a sheath freedom of more than 80% of the cases, and the people can be they will be out of the medication during the follow-up. The next best outcomes are with the temporal lobectomies, especially for hippocampal sclerosis, where almost 70 to 80% remain sheath-free with marked reduction in the drug burden over the years, and even 25 to 30% of the people will be out of medication in the long run, that is at 10 years follow-up. And of all these, focal cortical dysplasias are difficult to treat, and sheath freedom is around, I will say, 60%, followed by they need to be maintained on anti-epileptic drugs. At least 1 or 2 AED should be continued on a regular basis, lifelong. So these are the benefits. Finally, whether it is medical management, women with epilepsy, or surgical management, our goal is a holistic approach in the management of epilepsy with sheath control, improving the quality of the life of the people by improving the developmental aspects of the children, improving the behavioral aspects of the children as well as the adults, and also making them as one of the, they should be living like any other normal person and leading their lives with happiness. So that is what is about the management of epilepsy in the today's scenario. Thank you. Surendra? Nobody is there?
No questions.
No questions. That's okay. It's live, huh? So we can get up and go. It's clear that. Thank you.
Thank you.
Thank you.